First of all, good afternoon, everyone. I've been asking Dr. Ashok and Kulkarni ji to let us feature them and have them over for this case study. And they've been waiting for the project to get at the right stage. And I'm really excited that today we are featuring Institute of Health Management, Pachod. Founded in 1977, IHMP has spent over 4 decades working tirelessly to improve maternal and child health, adolescent well-being, and public health outcomes in underserved communities. I've worked very closely with the IHMP team, and I think what sets them apart is their data-driven, methodical, and deeply impact-oriented approach, ensuring that every intervention is evidence-based and scalable. For the past 5 years, IHMP has been leveraging Avni as a job aid application for ASHA workers, empowering them with visit reminders and decision support, real time data availability, structured training, and capacity building. I think their approach is not just about scaling fast, but about creating a replicable model of deep, sustainable impact, one that can collectively contribute to reaching the scale eventually. Today, we have the privilege of learning firsthand from the IHMP team about their journey, challenges, and key takeaways from implementing Avni. I'm certain there is a lot to gain from their insights, whether you're working in health, data driven program design, or digital transformation. So, without further ado, let's welcome the IHMP team. I'll first hand it over to Dr. Ashok Dyalchan. It's always fun to listen to you, sir. Dr. Ashok Dyalchan is founding trustee at IHMP and a source of inspiration. So over to you, Dr. Ashok, to share about a vision, mission of the organization. How did you come about IHMP? And then maybe like we can learn more from the IHMP team. We have members from different playing different roles within the IHMP team. So excited to learn from you all. Over to you, sir.
So, good afternoon to all of you. And just briefly to tell you, my presentation is going to be in four parts. Uh, can we change the slide, please?
Yeah,
Yeah.
and
So,
Kulkarni,
the
if you
four,
can move to the slideshow mode, that will just make it bigger for everybody. Thank you.
yeah. So, these are the four parts of my presentation. I will briefly tell you about IHMP's history, its vision and mission, the philosophy that we have adopted, and our current focus area. Next, please. So the first program that this organization started was maternal and neonatal health care through traditional birth attendants, DIEs, which was implemented from 77 to 82. It resulted in a significant reduction in maternal and neonatal mortality. More than 100,000 women and infants benefited from it, and it was replicated by the government of India at a national level. Next, please. From 1980 to 83, IHMP developed a strategy to prevent rather than correct malnutrition. This is an extremely important issue because most other organizations were waiting for children to get malnourished before intervening. The result of this intervention was that severe malnutrition reduced from 20% to 5%. More than 200,000 children benefited from it. And UNICEF replicated IHMP's innovation, the IHMP's model, in 11 states in India. Next, please. Um, from 87 to 2004, the organization ensured potable drinking water in 396 villages in two drought prone districts of Maharashtra. Uh, this was with the aim of reducing waterborne diseases. The water availability increased by 300,000 liters per day. UNICEF replicated IHMP's model in all the districts of this state. Next, please. From 87 to 2004, IHMP designed, it conceptualized, designed, implemented a very, very innovative program known as the Bal Panchayat program, where children really are involved in changing adult behaviors and in adult schemes and programs. So, over 50,000 children benefited directly from this program. But what's more important is IHMP trained 750 NGOs in India to replicate this program all over the country. And it was adopted by Plan International as the national strategy for the entire country. Next, please. So in 1998, IHMP was commissioned by the World Bank to design a behavior change communication strategy for Government of India. What was going on at that time, and I dare say is still going on in many states even today, is information education communication, where it is believed, assumed that if you provide information, behavior will change. It doesn't happen that way, and we changed that entire paradigm of behavior change from IEC, information education communication, to behavior change communication, to need specific behavior change communication. And here is where the Avni app really helped us, because when you assess, identify a need of an individual, then you can respond to that need by giving information as well as counseling and motivation. Next, please. From 1999 ongoing, we have been empowering unmarried adolescent girls through a 6 month duration life skills education program, which is really standardized and which we have shared with many, many NGOs in this country. The result of this, the outcome of this was the child marriage, the prevalence of child marriage reduced from 82% to 28%. This was scaled up, the intervention, life skills education, through 10 NGOs in Maharashtra, and over 100,000 girls benefited from it. We were able to bring about a change in child marriage on a very large scale. Next, please. From 2003 to is what is still going on. Even though child marriage percentages came down, we realized that certain percentage of girls were still getting married at an early age, before 18 years, the legal age of 18 years. And the present program is really to assess what their SRHR, the sexual, reproductive, and health needs are. Uh, the app that is being used is for assessing their uh, needs, their health needs. It is for increasing contraceptive use to delay age at first birth. It has increased utilization of maternal and neonatal care services and reduced maternal and neonatal morbidity. Our focus is on morbidity rather than maternal and neonatal mortality, following which post facto you can't do anything once the mother or child dies. And there's been a significant reduction in the prevalence of low birth weight babies as a result of this intervention. Next, please. Um, IHMP scaled up this program for married adolescent girls, the sexual and reproductive health of married adolescent girls, in 5 districts through a network of NGOs. The results were better than the pilot, and the program was evaluated externally. The findings were published in the Lancet, and there is a WHO publication which has described how this strategy was implemented. Next, please. Uh, from 2003 to date, IHMP is providing primary health care in slums of Pune city. There are 564 slums. Currently, we are providing out of this health services, primary health care services in 100 slums. When I say primary health care, it means the services of a doctor, of a nurse, of a lab technician, diagnostic, preventive, and curative health services. Uh, the population that is being served is 1,21,000 in the city of Pune, and we have deployed 3 mobile medical units, which are staffed by a doctor, a nurse, and a lab technician. Next, please. Now, to share with you the vision and mission of this organization, what we find is that after all, our work is with adolescent girls and with young women. And what we find is most of the problems that they face are because of the gender inequities that are there in our society. So, our vision is to reduce those gender inequities and facilitate a community which is free of discrimination against girls and women. The mission, the way we do it is health and development of women, adolescent girls, and children. And we focus on the most vulnerable and marginalized groups in the community, both from a socioeconomic point of view as well as from the point of view of medical need. Next, please. The philosophy of this organization is to improve the health and overall development of communities through piloting innovative interventions, through training, which is both for government as well as NGO health workers, and through research by providing research evidence. We do this through evidence based innovation, demonstration, and policy advocacy. The evolution of this whole um, strategy was we were approached by the government a long time back, several years back, when they were adopting the targeted approach. The targets were set in Delhi instead of in the state or in the district. We told the central government this is not going to work, and so they adopted the target-free approach. Workers felt, oh, now they don't have to do anything. There are no targets. So all the outputs and coverages dropped dramatically. That was the time when the health secretary at the central government level visited our organization and saw how we were assessing the need at the community level and adopted the what is now known as the community needs assessment approach, which we used as a manual system earlier and have now converted it to a digital system. Next, please. Our current focus is on married adolescent girls, young married women, and this is based on their vulnerability and need. Next, please. You will see the rationale why we are focusing on adolescent girls and young women, because maternal mortality, neonatal mortality, and prevalence of low birth weight, 3 to 5 times more in adolescent girls as compared to women. Anemia, 1.5 times more. Abortion, early abortion in the first trimester. I'm talking of miscarriages and spontaneous abortion, 3 times more. Post-abortion complications, 3 times more. Domestic violence, twice as much. Reproductive tract infections, twice as much. And therefore, if we really focus on married adolescent girls and young women, we can very quickly bring down mortality and morbidity rates. Next, please. So the lessons we have learned from all this is the app is effective in facilitating universal health coverage. We do a census, and when we do a census, we know exactly how many people in the community in our society are in need of services. We use the Avni app to make affordable for piloting innovations and small scale demonstrations. Whom are we piloting this for? For both the NGO sector as well as the government. The purpose of pilots and demonstration is finally, ultimately, policy advocacy. What we are saying is we can't create small oases of excellence. This is a large country, it has large problems, and we need these pilots to be really affecting and benefiting girls and women on a very large scale. And that can happen only when the government replicates these programs. And the biggest lesson for IHMP is that unless we make the Avni app cost efficient for large scale replication, really it'll remain at a pilot level forever. Thank you. Yes.
Thank you, sir, for your introduction, vision, philosophy, and all about IHMP, HRTs, their aims and objective. My name is Gopal Kulkarni. I worked with this organization since last 26 years. Now I am within a 5 minutes. I would like to briefly tell you how, why, and when we started the journey with the Avni and Samanvay Foundation. Yeah. So, for my first question is why IHMP digital app with only format? So, obviously, to facilitate early identification of needs and morbidity. In our country, if you look at the uh, barriers, or you can say root causes of maternal mortality, morbidity. So one of the key cause would be the delay in identification of symptoms, delay in reaching facilities, and delay which happen at the level of facility. So to address those at least first two delays, we have started community need assessment and morbidity surveillance. So this is the objective to reduce the delay in reaching facilities and to improve the health service implementation and coverages. So IHMP designed our manual MIS system using CNA approach, as Dr. Dayalchan stated that. And then what we have done that we have transferred that manual robust MIS system using the Avni platform. So that's why Avni's platform adapted to design app for IHMP's program, or you can say MIS. And design and testing of this app was carried out in 2019-2020. This app is primarily designed for ASHA volunteers nowadays, but this app can be very effectively used by any community health worker. But specifically, this is primarily designed for ASHA volunteers. So what it includes, or how it got designed. So IHMP's protocol in Avni app designed to improve maternal health, neonatal health, child health, reproductive health of women, and family plan. So currently, 100 ASHA volunteers from Pune city and 36 ASHAs from rural parts of Sambhajinagar district from Maharashtra are using this app, and how they are using. So, what is the benefit of this app? So, as Dr. Dayachan also clearly stated that we are using this app for denominator-based learning. What does it mean? That we generally start with the census information, which will give us all the target groups, numbers, and everything, and we do our planning based on the denominators. Data-driven monthly planners for service providers, provision of need-based counseling, that is very important. So we do conduct the information needs during the health needs assessment, and based on that information needs, we have developed protocols to provide need-based counseling and behavior change communication, and most importantly, monitoring of health needs and utilization by mid workers. That is another use of our app, and obviously using that information there is it facilitates rational reference and utilization. So another use is real-time data access by grassroots level volunteers like ASHAs, ANMs, and other service providers. So it impacted on significant reduction in paperwork for ASHA volunteers. So these are the future plans. So right now our IHMP Avni app has models for maternal health programs, child health programs, neonatal health programs, and reproductive health programs. But we would like to include these models also sequentially in future. So for anemia, dietary behaviors and nutrition status, as Vinay also correctly stated that they are struggling with the WHO cards, etc. So it comes there. Non-communicable diseases and communicable diseases. So this is very brief introduction of this IHMP's Avni app. Now, in the next subsequent sessions, I would like to introduce one by one those who are using actually this app at the community level. So first, I would like to invite Ms. Lata Bole, who is Asha volunteer delivering services in the slums of Pune city. May I request to Dr. Prajakta and Lata Tai start your talk. Yeah, Prajakta.
Yes, sir. Yes.
So you again muted. Bola Lata Tai, bola.
नमस्कार. माझं नाव लता प्रकाश होले. मी शिंदे वस्ती भाग 1 मध्ये काम करते. शिंदे वस्ती भाग 1 मध्ये काम करते. माझी लोकसंख्या आहे 2500. मी 10 वर्षापासून हे काम करत आहे. मोबाईल ॲपचं काम 5 वर्षापासून करते. आणि हेच पहिलं काम पहिलं घरभेटीचं काम असतं आमचं. पहिली म्हणजे पाळी चुकली का ह्यावरून मग आम्ही महिलांना महिलांची गरज ओळखून मग त्यांना सेवा देतो आणि समुपदेशन करतो. एक पाळी चुकली का ह्याच्यावरून आम्ही महिलांना कुठली गरज आहे, त्यांना कुठली सेवेची गरज आहे हे आम्ही त्यांना गरज ओळखून सेवा देतो. आणि आता माझे महिन्याचे घर भेटे आता आम्ही ॲपमध्ये आम्ही काम करताना मोबाईल उघडल्यानंतर आज आम्हाला समजतं आज आमची घरभेट कुठली राहिली आणि कुठल्या महिलेला घरभेट द्यायची, गरोदर मातेला द्यायची का पेनची व्हिजिट आहे हे आम्हाला आमच्या मोबाईलवरून लगेच समजतं की आपल्याला. आणि कॉम्प्लिकेशन महिला पण त्यातून समजतात की कोणाला कॉम्प्लिकेशन आहे, त्यांना सेवा काय गरज द्यायची हे त्यांना आम्ही फ्लॅश कार्डाद्वारे सांगतो. त्यांना आम्ही जर ह्याच्यातून असं समुपदेशन करणं जर फ्लॅश कार्डाद्वारे समुपदेशन केलं तर त्यांच्या लगेच लक्षात बसतं. म्हणून आम्ही त्यांना फ्लॅश कार्डाद्वारे समुपदेशन करत असतो. आणि महिन्याच्या शेवटी सगळ्यात डाटा येतो. म्हणजे कुठली महिलेला घरभेट द्यायची राहिली का, कुठली महिला चुकली का हे आम्हाला त्यावरून समजतं. कुठल्या महिलेला कॉम्प्लिकेशन आहे मग हे आम्हाला समजलं की मग आम्ही त्या महिलेला गरज ओळखून त्यांना सेवा देतो. एक तर पहिली सेवा आपली सरकारी दवाखाना, नर्सबाई आणि फिरता दवाखान्याचा तर फार आम्हाला उपयोग होतो. कारण एखाद्या गरोदर बाईला काही त्रास झाला किंवा एखाद्या बीपी वगैरे बीपीचा वगैरे त्रास असला, बीपी चेक करतात ना ते फिरत्या दवाखान्यात. मग बीपी चेक केल्यानंतर जर बीपी वाढलेला असेल तर आम्ही त्यांना लगेच सरकार दुसऱ्या दवाखान्यात पाठवतो. हे फिरत्या दवाखान्याचा तर फार मोठा उपयोग होतो. मागे एक उदाहरण परत आणखी नर्सबाईंची पण सेवा मिळते. सरकारी दवाखान्यात पण आम्ही त्यांना पाठवतो. असे 3 प्रकारे आम्ही त्यांना महिलांना सेवा देतो. आणि फायदा आम्हाला ह्या मोबाईलवरून इतका फायदा झाला की म्हणजे आमचं महिन्यात पहिले म्हणजे आम्ही रजिस्टर घेऊन फिरत होतो. आता आम्हाला रजिस्टर घ्यायची गरज नाही, पेन घ्यायची गरज नाही लागत. आम्ही मोबाईल ॲपवरती सगळं काम करतो आणि मोबाईल ॲपमध्ये सगळे प्रश्न विचारले जातात. त्याच्यातून एक प्रश्न सुद्धा विचारायचा राहत नाही. त्यामुळे त्यातून आम्हाला गुंतागुंती असलेल्या महिला समजतात आणि कुठल्या महिलेला कुठली ह्याची सेवेची गरज आहे हे पण समजतं. आणि जनगणना पण आमची एकाच वेळी होते, नाहीतर ते आम्हाला सारखंच करण्यासाठी लागत होतं. आणि जनगणनेचा आणि गुंतागुंती असलेले महिला लगेच समजतात आणि त्यांना आम्ही घरभेटी भेट देऊन त्यांना समुपदेशन करतो आणि दवाखान्यात रेफर करतो. थँक्यू.
So, just I would like to summarize the key learnings, what she told that right now in Marathi. So, she's telling that no paperwork. She is free of all paperwork. She is enjoying her work using the digital app. So, lot of burden of writing has reduced. Real-time update of census information. Nowadays, she don't require to go again do the census every year. Now her census is being updated on a monthly basis so that she is getting the census information at any time of point in any month. What she told that there is improvement in planning and implementation of home visit, coverage of home visit. So now whenever she start her mobile app, then she found that identify that how many visits she is supposed to do on that day. So it helps her to cover all those visits. And the most important thing, what she said that now there are 11 symptoms of antenatal morbidity, 10 of intranatal, 11 of postnatal, and 14 of neonatal morbidities. So now what she stated that now she is not missing out any symptoms while asking those symptoms during their home visits. I think there is an improved efficiency in morbidity surveillance has happened. So thank you, Latatai, for all these things. Now I would like to invite Ms. Pranjali Gofne, who is working in this program as a field facilitator. She is also providing her services directly to the communities, and she will tell about how she is using this app. Pranjali.
गुड आफ्टरनून एवरीवन, मेरा नाम प्रांजलि है। मैं प्रांजलि गोफने गए 3 साल से IHMP में एज अ फील्ड फैसिलिटेटर इस पद पर काम कर रही हूँ। नेक्स्ट स्लाइड सर।
यस,
पहले तो
Hello.
पहले तो हैंड होल्डिंग का काम करते हैं, जैसे कि 5 एरिया एज अ फील्ड फैसिलिटेटर मेरे तरफ 5 एरिया होते हैं। 5 एरिया में वीक में एक बार हम वहां जाते हैं, विजिट करते हैं। उसमें क्या क्या देखते हैं, हैंड होल्ड क्या क्या देखते हैं, होम विजिट अवनी ऐप में होम विजिट बराबर हुए हैं या नहीं है ये चेक किया जाता है, कि जैसे कि कितनी विजिट प्लान है, कितनी विजिट ओवरड्यू हुए हैं ये भी देखा जाता है। जो कुछ क्वेश्चन आर है वो क्वेश्चन आर बराबर पूछे जा रहे हैं या नहीं, सिम्टम्स बराबर जो कुछ आंसर आया उनको फिल बराबर किया जा रहा है, ऐप में भरा जा रहा है या नहीं भरा जा रहा, वो भी देखती हूँ। उसके बाद जो कुछ इंफॉर्मेशन जो मिली है उनके बेस पर काउंसलिंग नीड के अनुसार नीड के जरूरत के अनुसार उनको काउंसलिंग हो रही है या नहीं हो रही, ये भी देखते हैं। उसके बाद जो कुछ प्रोग्राम है, प्रोग्राम के अनुसार उस महिला के विजिट प्लान हुए हैं या नहीं हुए हैं ये भी देखा जाता है। उसके बाद जहां जहां आशा दीदी को अपनी ऐप चलाने में कुछ दिक्कतें आती है वहां मैं मदद करती हूँ। जैसे कि डेटा क्वालिटी कैसी है ये कैसी चेक किए जाती है ये, जैसे कि जो कुछ अपने एरिया में जितनी एलिजिबल कपल है वो सभी अपनी ऐप में है या नहीं ये भी चेक किया जाता है। उसके बाद जो कुछ मैटरनिटी हेल्थ प्रोग्राम के लिए जो महिलाएं एलिजिबल है वो महिलाएं अपनी ऐप में है, डिजिटल ऐप में उनकी एंट्री की है या नहीं की है भी देखा जाता है। कि इस स्लाइड में जैसे कि देख सकते हैं कि यहाँ पर टोटल टोटल एलिजिबल कपल यहाँ नीचे एकूण नोंदणी में देखा जाता है, और यहाँ पर प्लानिंग में कितनी प्लानिंग है विजिट और कितनी ऑलरेडी है, उनको कितनी करनी चाहिए थी और कितनी हुई है नहीं की है, ये भी देखा जाता है। उसमें से जो कुछ मैटरनिटी हेल्थ के लिए और रिप्रोडक्टिव हेल्थ के सिम्टम्स जिन महिलाओं को है, उनके बराबर उन्हीं ऐप में टिक किए हैं या नहीं है, सिम्टम्स भरे गए हैं या नहीं है, ये भी चेक किया जाता है। वो ऐसे चेक करते हैं कि जो हम जाने के पहले जितनी महिलाओं को विजिट किए है आशा दीदी ने, उनमें से 5 महिलाओं को हम रैंडमली विजिट करते हैं, और रैंडमली विजिट करके उनको जो सिम्टम्स है उन्होंने जो बताया है वही ऐप में भरा है या नहीं भरा है, ये भी चेक करते हैं। जो कुछ माइक्रो प्लान जो मेटाबेस से जो हमको 5 एरिया का जो माइक्रो प्लान मिलता है, उस माइक्रो प्लान का हम ऐसा यूज ये करते हैं कि जो वो हमको उसकी मदद ये होती है कि जो कुछ हाई रिस्क मदर है, जो महिलाओं को जो कुछ आजार है और जो महिला सेवा से वंचित है, उनको जल्दी से जल्दी पहचानते हो और उनको सेवाओं से जुड़ाने के लिए मदद होती है। उनको क्या हाई रिस्क मदर को हम होम विजिट भी करते हैं और उनको नीड बेस्ड काउंसलिंग भी करते हैं। वो इस मेटाबेस से ये इजीली हो गया कि हमको जल्दी से वो लिस्ट मिलती है, तो जल्दी से हम उनको काउंसलिंग कर सकते हैं और सेवा से जुड़ा दे सकते हैं। उसके बाद अगले हफ्ते में जब हम जाते हैं तो हम उनका फॉलोअप भी लेते हैं, वो सेवा गए क्या, उस ट्रीटमेंट ली है या नहीं ली है, उनको क्या ट्रीटमेंट के लेने में कुछ दिक्कतें आई होगी तो उनको सॉल्व करने की ये ट्राई भी हम करते हैं। जैसे कि ये लिस्ट है मेटाबेस से हाई रिस्क मदर की हमको लिस्ट मिलती है, जैसे कि पीएससी का नाम आता है, स्लम का नाम आता है, नेम ऑफ प्रेग्नेंट वुमन। इसमें हाईलाइट किया जाता है महिलाओं को जिनको कुछ कॉम्प्लिकेशन हो। इससे हमको ये मदद होती है कि जो महिलाओं को कॉम्प्लिकेशन है, हम तुरंत जानकर उनकी होम विजिट कर उनको सेवा से जोड़ दे सकते हैं। हम ये भी देखते हैं कि जैसे कि एक्चुअल में हमारे एरियाज में कितने हाउस होल्ड है और कितने हाउस होल्ड ऐप में रजिस्टर है, पूरे है या नहीं है, पूरे का प्लान किया है या नहीं किया है, ये भी देखा जाता है। उसके बाद जो कुछ स्लम में जो कुछ महिलाएं स्लम में इनरोल है, इसी प्रोग्राम में इनरोल है, उनको ऐप के SRHR सर्विस के एलिजिबल है, उनको सेवाओं से जुड़ा गया है या नहीं है, ये भी देखते हैं। उन्होंने सेवा ली है या नहीं, ये भी देखते हैं। जहां पर ये नहीं हुआ है एक्चुअल में जितना होना चाहिए था, और एक्सपेक्टेड जितना होना चाहिए था और जितना नहीं हुआ, तो वो क्यों नहीं हुआ, उसका वो गैप आइडेंटिफाई करके हम वो सॉल्व करते हैं। इस ऐप्स के वजह से हमको रियल टाइम डेटा अवेलेबल होता है, तो वो हेल्थ यानी जो कुछ फील्ड में काम करने के लिए इजी जाता है। जैसे कि जो कुछ पेशेंट है उनका फॉलोअप लेने के लिए या हेल्थ के जो सर्विसेज है वो प्रोवाइड करने के लिए हमको उसकी मदद होती है। जैसे कि कोई हाई रिस्क मदर हो या वंचित वुमेन हो जो सेवा से वंचित है, उनको भी हम सेवा को जल्दी से जल्दी प्रोवाइड कर सकते हैं। उसके बाद हमको ऐप के वजह से नीड बेस्ड काउंसलिंग के लिए भी उसकी मदद होती है। और जहाँ जहाँ जो कुछ आशा दीदी जो कुछ प्लानिंग करते हैं होम विजिट के, और जो कुछ होता जो कुछ प्लानिंग करते हो हेल्थ फॉलोअप विजिट हो या आरटीआई की कुछ विजिट हो या नीड बेस्ड असेसमेंट के विजिट हो, उनको मदद प्लानिंग करने के लिए मदद होता है इसे।
Yeah, thank you, Pranjali, for your very informative presentation on how you are using the data or information which is being collected from the Omni app for your implementation purpose. Okay, now it's turn of Dr. Pankaj Mauri, who is looking after this program. So may I request to Dr. Pankaj to start his talk.
Hello
Dr.
everyone.
Pankaj.
Hello everyone. I am Dr. Pankaj Mahure. I am working in IHMP from last 7 years. And right now I am a program manager here. So as a part of program management approach, we leverage the data from IHMP digital app. I extract the data from Omni reports, then I systematically compile and analyze the data to identify trends, variation in health indicators, and service gap. And we use the data for strategic planning, implementation, and management purposes. So we extract key indicators from the reports, such as we extract women with desire to use temporary family planning methods, number of family planning users, and pregnant women with complications like anemia, hypertension, from the total registered pregnant women. So purpose of the compilation and consolidation is to analyze Asha's performance across multiple indicators to find consistency and to assess the performance differences between Ashas on specific indicators. Like we look for the within and between variations using the ANOVA principle. We compare actual versus plan to identify gaps and barrier, and after finding the gaps, we identify the reasons for the gap. It is because of the demand sides or from the supply side. And based on the analysis, we plan our implementation, we plan our strategies and implement that strategies in the field. So we use the dashboard for effective utilization of resources. Like it helps in tracking gaps in services, ensuring proper distribution of medicines, ANC checkups, and community outreach reports. Based on the reports, we allocate staff efforts, supplies, and interventions where they are most needed. Rational referrals means patients are referred to the different level of care based on the severities of symptoms like primary, secondary, and tertiary level of government hospital. And we use the report to decide where additional intervention is there needed, like BCC sessions of field facilitators in the community, or ASHA training, or community mobilization efforts where is required. We strengthen SRHR program by focusing more on the areas where more inputs are needed. So we coordinate with government officials in the urban primary health center to ensure the provision of minimum standard maternal care services. They play a key role in providing antenatal care, postnatal care, and maternal care services. We ensure timely antenatal care checkups for pregnant mothers, to identify and referring high-risk pregnancies to higher healthcare facilities, and strengthening RTI or STI screening and treatment services. We do regular follow-ups with urban PSCs staff to ensure timely access of medicines for maternal and reproductive health of women. Thank you.
Thank you, Dr. Pankaj. Now, for any intervention one of the key overarching inputs is capacity building of the volunteers. So now I would like to request to Ms. Dhanashri Doshi to briefly discuss how they have conducted the capacity building program for this IHMP only one. Dhanashri, over to you.
Yeah, sir, I'm not able to see slide.
Now it is there. These are the slides.
Yes.
Dhanashri, you have to
Okay.
click on
Yeah,
the tab
yeah, yeah.
up there where it says work.
Yes. Hello, everyone. Good afternoon. I'm Dhanashri Joshi. I'm working in IHMP from the last 3 years. Basically, I'm going to say about
Dhanashri, you are not
induction
audible.
training for Asha or Asha's experience about training phase 1, in which on Avni portal, such as follows: smartphone, or they don't know about any, in them about how we teach them how to the importance of username and passwords. We gave them and basic introduction to Avni dashboards. Next, total. Okay. Next, we in phase 1, part 2, we do census and identify the target group for monthly surveillance. Use of census forms in Avni app, such as we do, matlab, we teach them how to register individual, how to register household, and how to sync data or transfer data to the server. This session was conducted at induction training for with participatory method and practice sessions also. And after induction training, field facilitators undertake handholding for ASHA in the field and or at village level. Second phase, after completing census of 2 months, Ashas acquire following skills like identify the eligible couples, enrollment of beneficiaries at respective programs, and use filters for different types of program. Participatory method, this also conducted as participatory method and practice sessions, and Asha was supervised by field facilitator. Next. The third phase, after enrolling eligible couples and detecting eligible couples, phase 3 training for ASHAs regarding maternal health, that is pregnancy. We introduce them to basic of, introduction to maternal health, skills for enrolling pregnant women in maternal health program, that is pregnancy, how skills for planning the next antenatal care visit, and these skills undertake surveillance of maternal morbidity through practice sessions, and mock interviews with the field facilitators. Last one, the induction training phase 4, which is mainly used we conducted for postnatal care and neonatal care. These skills provided for postnatal cares and neonatal cares. In this training, we teach them how to plan PNC, that is postnatal care, and home-based neonatal care visit in the family or household, and how to fill the form of birth child. After training, Asha was supervised by field facilitator. The total duration of this induction training was almost 10 days. Thank you.
Thank you, Dhanashri. Thank you, Dhanashri. Just I would like to summarize what she shared that the induction training was the one of the crucial stage in implementing and rolling out Audi. It was taken in phase manner. There were 4 training programs were implemented. Uh, we have kept the gap of 1 or 2 months in each training program to assess whether they are doing the learn skills actually in the fields or not. So at the end of 4 months and 10 days duration, we saw that there is a significant improvement in their skills of implementing this only. Now, this is the time to share with all of you that what type of impact has made by this program. See, this digital app, or you can say community need assessment, is one of the component of the comprehensive program. Now, last year we have done a very robust evaluation of this program. Now I am going to share with you what all impact has made because of this program. So I use two different methodologies to present this data. One is the causal experiment study, which was conducted in the slums of Pune city using pre-post control design. And the second thing is we have started this Omni app since 2020, and we have analyzed the data, time series data using the trend analysis. So these are some key results from the service data. Here you can see that coverage of beneficiaries with Omni, which has increased from 66% to 99%. Then these are encounters, how many were planned and actually how many were carried out. So it also got increased very significantly from 71% to 81%. Look at this. This is the graph which shows you identification of pregnancies. So here in the first year, you could find that there is a huge gap, but after 4 years, the gap has got minimized. This is the proportion of these young married women who are using temporary family planning method. It also got significantly increased from 5% to 32%. All this is the program data. To validate this program data, we have conducted a quasi experimental study in the slums of Pune city. That I would like to share with you some of the key important things. The first indicator is how percentage young married women received home visit by Asha worker. So look at this. It was increased from 31% to 52%, but in control area, it is 46%. It itself demonstrated that the impact of this IHMP zoning app on the coverage of home visit by Ashas. Again, similarly, there is significant improvement in home postnatal covered under the HPNC visits by Ashas. Then percent in married women utilize minimum standard antenatal care. It got also significantly increased from 44% to 61%. Thus, then how many are using temporary contraceptives? It also went up from 16%, 70% to 36%. There is no significant change in control area. So what we have learned from this experiment that there is a significant improvement in home visit by Ashas, then need-based PCC, receipt of need-based PCC, then active linkage of beneficiaries to the service providers, and utilization of services by the slum dwellers. So it shows the trend in achievement of universal health coverage by the urban people. Thank you. I think, yeah, thank you.
Okay.
So then now it's done. I would like to ask Arjun to facilitate henceforth.
Yeah.
This is
Thank
all
you so
about
much.
IHMP and their program.
Yeah. Thank you so much, Kulkarni ji.
Anytime I ask. Otherwise, you can ask to project us.
Yeah. I mean, my question was around whether they have they were using mobile phones earlier, or this was the first time that they used mobile phone. So my question was around that as such.
So so when they started using Audi, so earlier that they were not using smartphones. But after this Audi and everything, they are now used to use the smartphones. So that is the thing, and this is being implemented in around 140 ashas. So some are having their own phones, own Android phones. There is a mixed community. So there are several ashas who are expertise in using social media and etc. etc. But there are still some ashas who are not comfortable using the Android phones. But that's why what Dhanasri stated that we had our first session was on Android phone. How Android phones are used, how this will be made more comfortable for them. And you are also aware that meanwhile, since 2019 to 2034, the period had changed, and everybody now is using the Android phone and all these things. And several programs are going on, digital Sakhi and all these things.
Right. Mm. Yeah, anybody has any questions?
I have a situational question, not maybe Gopal sir can answer or Arjun also can take it up. While listening to this, I was thinking about this question. Avni has introduced and lot of things which were manual and which were difficult to kind of track on a real-time basis have been made possible to do it and have better tracking, better outcomes. But at present, what are two challenges which you feel still need to be addressed, which even having the app is not able to address and you want to transition that to the app or the technology?
Kulkarni ji?
Gopal sir,
Yeah. So
it's more like a situational question because ये वाला ऐप यूज करके तो आप बहुत सारे बेनिफिट्स हुआ है, बहुत सारे चीज इंप्रूव हो चुके हैं, बहुत सारे आउटकम आपने अचीव कर दिए हैं, लेकिन ऐसा एक दो चैलेंजेस आप जो फेस कर रहे हो आपको लगता है कि ये ऐप में लाना चाहिए, ट्रांजिशन करना चाहिए, जिससे कि और इम्प्रूवमेंट हो सकता है आपके लिए?
So one of the key challenges is how these analytics will be made more effective. That is the challenge. So at the level of entering information for longitudinal data entry is very good with Audi. But after that, so why we are collecting all this information for management? So we always try to collect that information, make that information in the form that will be very effectively used for management. And once we use that information for management, does it mean that for proper planning and implementation and monitoring of this program? Then we can say that this is really working. So what I would like to say that there is a huge challenge of preparing database reports. It takes a lot of time. Everybody is aware of that. And then, for example, now I have started using R at my own level, try to find out because there are several situations we generally we are come across, and as per the need, we are taking that data from our web console, and we are making the small R programs, and we are addressing those problems. This is the challenge. Another challenge is sometimes what happens that because of whenever the new version releases new version, sometimes, not all times, sometimes it takes some time or it gives some hurdles in smoothening that. That is another challenge. And the third one is challenge is how to keep that information safely. So to address from the bulk, that is someone way challenge, not our ones. So these are some of the key challenges which I would like to say that in terms of technology. In terms of program, we are doing that.
Yeah. I'm most of it was asking for technology.
Yeah, technology. Yeah.
Yeah, I would say that soon, I think connecting with beneficiaries, that could be something that we could maybe work on. Like where beneficiaries, if they start their educational level start getting improved, can some feedback, can some connect be given with the beneficiary directly? Like when a ASHA worker records something, can we like push out, let's say, a counseling advice or some sort of a report of the visit to the beneficiary as well? That could be another thing. And even I don't know, in us when we talk of scale, then maybe like we have, right, we take a Ola Uber ride and after that we get a feedback form to really share our feedback. How was the interaction? Maybe like we don't know at when the programs get rolled out at scale. Uh, we don't know how each and every interaction is happening really. So that could be another way that a feedback could be sent to the individual citizens as such to get the feedback about the interaction that they had. So they
And
If I
can
may,
become much
if
more
I may come
engaging.
in, Mr. Arjun,
Yes, please, Dr. Ashok.
I think you hit the nail on the head. All of us are very fond of pilots and doing things at a micro level. And at some point of time, we need to ask ourselves, why are we implementing these pilots? Why is our entire emphasis on the community and community related challenges and problems? At the end of the day, if we want this to have really an impact, we have to upscale it up. And the scaling up has to be done through the government. Now, the government system itself has an IT system, but it's meant only for reporting. So for me, the biggest challenge is how do we synchronize this system with the government system?
yeah,
That's one. Number two, it's very easy to train 100 ashas in Pune city. How do we train? How do we simplify this app in such a way that 1.5 million ashas in this country can use it at a national level? That, to my mind, is the biggest challenge. And unless this technology is simplified, training is simplified, I don't think that's going to happen.
Yeah. Ashok, does that help answer your question?
Yeah, that's absolutely help. And I always think about the solutions in terms of in today's time, how I always go back to creating the collaterals of small videos, small information in vernacular medium, which really helps the people who are using it. Because once the training is done, sometimes if you're doing training for 50 people, only 2 or 3 people pose questions or 5 or 6 questions comes up. And sometimes they understand at that point of time, but when they're using, they don't have enough things to refer back. So those are the things I try to implement with them to give enough collaterals to them, which can be used in form of short videos, short snapshots, those things which really help them. And second part is that how many questions comes when we are doing with the ASHA workers who are using it. How can we create a space for them to kind of ask those questions regarding technology? Because sometimes they are the main users and they should kind of give ideas to improve the app. And that is always the focus. I think I'll leave with that thought that we should always focus on the end user who is on a day in, day out using it.
Sure. And if you were to conclude, maybe are there any 2 or 3 tips, Kulkarni ji or Dr. Ashok, that you would like to give to whoever is embarking on this journey of digitally transforming their program, implementing something like Avni? What if there are any tips, very shortly? We are already we've overrun. But if there is any quick 2 or 3 tips that you would like to give.
So from my side, I think those 2 or 3 tips are very specific. I think every program needs to start with a census, and Avni can really help out there, because that is the only way in which we can say nobody gets left out. We have identified every single house, every single individual in that community. So census is is an important thing for universal coverage. The second thing is when we use the word evidence based, what is it that we really mean by it? I think we mean where data is used for planning, monitoring, and evaluation, where it is used as the foundational basis for program management. That is what I would define as evidence-based management. We need to use this data not only. So, if we talk of healthcare, and I'm sure this is true of education and livelihood as well, if we talk of healthcare, there are two aspects to it. One is identifying the need, which can be done by professionals, but the other is the person who has the need wanting to change their health seeking and health utilization behavior. And therefore, the use of data for information needs, for counseling needs, I think that is extremely important when it comes to the Avni app. It's used for monitoring our workers, or all the people who have made presentations have made it amply clear that this is being used for monitoring inputs, outputs,
Outputs.
and outcome on a real-time basis. I think that is the strength of this. And finally, I would say government is fed up of hearing the word pilot. There are pilots going on all over this country. Let's move from pilot to scaling up and replication.
Yeah, that made a lot of sense. I heard a word term going around somewhere called as pilotitis. So yeah, yeah, interesting that you mentioned about it. And yeah, we need to move maybe out of that. Cool. If there are no more questions, then Vinay, maybe we can conclude this section. If you have any closing note for the monthly meetup. Thank you so much, Dr. Ashok, Gopal, Latatai, Prajakta, Pankaj,
Dhanashri,
Anashri. Thank you so
Hole.
much. Thank you so much for taking out the time and sharing your learnings over here.
Yeah, that was supposed to be my closing note. Thank you everyone for joining in, and hopefully, I'll probably, once this is on YouTube, I'll probably go through it a couple more times to understand this better. Thanks a lot for joining, and see you next week, next month, I guess. Bye.
Thank you. Yeah, bye.
Thank you.
Thank you.
Thank you. Thank you very much.
Thank you.
Bye-bye.
you.